rules for the meeting in terms of, or at least just, say what we should do doing, some of the things keep your, in terms of making sure you mute your mic and all that kind of thing. So I'm going to hand it over to Kim to set the rules of the road. Then I'll do my welcome and then and hand it over to Caitlin, and we'll dive right into the agenda. So,
hey Valerie, I can give me 1 second to switch over to my headset.
Did we? In there? I was just trying to see if we lost Kim.
We may have lost Kim because I don't see her. So basically, what we're going to do today is to try to get through this agenda. We're going to Caitlin will go over the agenda with you, and I'd just like to welcome everybody. I'm not as good as recognizing all the new faces and all that, so that'll be with Caitlin's lap. But what I just want to say is I am so grateful for the fact that we've started the CCCT monthly meetings again. I really believe this is the bed work that we need to do in the county in order to help people who are at risk. And I think that you all are inspired to get that done. We're going to really set the rules of the road for this coming year. 2024 is going to be the year that we put in solid infrastructure for people who need help. And that's our goal. And that's one of my personal goals. In this meeting, we're going to talk about what the goals of the CCCT are. We're going to go over some cases and also end up with the pathways to equity mobile van expansion. So I think that I would just want to say to you all again, thank you all so much for participating. I really want to become a cohesive group. I really want to be mission driven, and we're going to make sure that all the programs that do care coordination in Prince George's County are effective and we actually move the needle. So with that, I'm going to hand it over to Caitlin for making sure that we recognize all the new faces and further the welcome. Caitlin?
Yeah, absolutely. So I'm actually going to stop sharing for 1 second so that we can see your face or at least hear your voice if you are new. So if this is your first time at CCCT, please come off mute and introduce yourself. Anybody new?
Good morning. My name is Priscilla Lissick. I am the Director of Homeless Services at the Coordinating Center. I am new to this meeting. We currently serve homeless individuals in other counties and have been interested in Prince George's County and are here to see how we can help support solving homelessness within PG County.
Awesome. Well, welcome. We're so excited to have you. For everybody who's a returning member, can you just put in the chat your name and your position and your organization? Anybody else new? All right, then we will keep going through our agenda here. So as Dr. Carter said, one big thing that we're going to focus on today is figuring out what our goals are going to be as a group. So I know we spoke about it a little bit last time that and I apologize, I'm trying to make sure you guys are seeing the right slides. Okay, so let me know if anything's wrong. But we really need to, within the context of the Prince George's Healthcare Action Coalition, of course, CCCT is now part of the coalition. We have to develop a community health improvement plan. And so that plan, I know we talked about this a little bit last time, but I'm just going to kind of refresh us, which is that we take the results of the community health needs assessment and we look at them and decide collectively what are we all going to work on as part of our strategy for collectively positively influencing health in Prince George's County. So of course, CCCT was created to address really primarily social determinants of health and access to care. So just to reiterate, our vision is Prince George's County is a place where everyone has access to high quality and effective healthcare services that are well managed, seamless, and tailored to their specific needs. And then our mission is empowering healthier lives through efficient care coordination with a strategic systems approach. So our next steps, as we kind of just talked about, we are currently at step 1 here, which is to define our goals and objectives. So I know you all, I'm sure, gosh, I'm just having the hardest time here. I apologize. I was not, it's like it just kicked me off of sharing. Hold on. And we lost Kim. So sorry. We'll bear with our technical difficulties. If I do this is not really presenting, but for some reason, all right, this is what it's going to be because it's not letting me do it in presentation mode, but you guys can all see this. So what we want to do in terms of our next steps, we want to be able to define those goals and objectives. So we're working on making that community health improvement plan, which involves constructing our community goals for health improvement and then making sure that we have measurable objectives that relate to each goal so that we're tracking our progress and, collectively working together to move the needle. And then after that, we'll identify potential strategies. So that's, exploring evidence-based strategies to address our specific goals, prioritizing the strategies, realistically. We're a group with really high energy and a lot of committed people, but we also all have jobs of our own. So to figure out like what is reasonable today based on the available resources and the political climate, all that kind of stuff, and then develop our action plan. So work on outlining the steps to implement each of the selected strategies, defining the timelines and who's responsible. So this is where we are in terms of developing the community health improvement plan. We are going to start with a brainstorming session. So participation.
Hi, I'm sorry. Is it frozen or is it me?
Yeah, I couldn't hear either.
Okay.
Yeah, she's frozen.
I think Caitlin is frozen.
I'm worried something serious is going on with Microsoft Teams. I
am
apologize all for these technical glitches. I'm almost back on my computer side, and then we can work on pulling up the Jamboard. But I saw that Taylor put the link to the Jamboard in the chat. So until we can share the screen, please feel free to start thinking over some of your ideas for goals, and we can have an open discussion. And Dr. Carter, if you want to kind of start talking about your vision and some of the ideas you had for goals, I think this would be great.
Oh yeah, so I just wanted, you all to for the CCCT, and I think I started out the meeting like this. We have high lofty goals, to improve the care for especially high risk people by doing care coordination and be sure that the CCCT plays an active role in sort of overseeing how the efficiency of how care coordination is done in the county, setting standards, and understanding how to improve interventions that that happen in our county, and get to the point where we can actually move the needle for people at high risk. So, but we have to have, you know, for our CCCT, we need to have concrete. We need to have some goals and set some goals and then have some objectives, and without just coming in and dictating it. What we decided is to have you all actively participate to determine what are our goals. One of the things I discussed in our internal meeting is that one of the goals of the care coordination, the CCCT, is to actually decrease hospital readmissions and ER usage. That's one of the goals that we know that we have as a unit, because a lot of the efforts that are driving care coordination in this state is linked to that. But there are other goals that we have to delineate. And Kim was put up 4 categories that you might think about, and then think about others. And so without me talking too much, what you want to do is to go, and I'm not Mr. Jamboard, so I'm going to let Kim tell you how to go about doing this. But basically, you can post your thoughts on this board, and we want everybody to post their thoughts on the board. It's just like writing a sticky note and posting it to the board. So, Kim, if you can give them a little bit of the logistics and then let them go at it.
Yes. Hi, everyone. Thanks for, again, for your patience with our technical glitches this morning. So you should be able to access the Jamboard using the link in the chat from Taylor, and you can add, you can go over here, like you see Taylor doing to the left, add a sticky note and put your ideas in. And then we can just kind of have an open discussion around these ideas and see what fits and what's feasible, and we can discuss prioritization. And then just to give everyone an idea, we added these headers based on the feedback that we received from the survey, the participant survey, around barriers that our participants were experiencing and and access to care. So, and if anyone doesn't have the access to join the Jamboard, feel free to just speak up and have a discussion, and we can capture some of the discussion points and add it to the Jamboard as well.
Yes, and also if you're adding something and you'd like to elaborate or get the conversation flowing, feel free to say what and why you're adding something, and we can build off of each other. Okay, so I'm going to pick on somebody who wrote something. So increasing access to low cost or free technology. First of all, gold star for being the first person to write something, but can you elaborate a little bit on what technology specifically? Like, is this are you thinking patient facing technology or like care coordination technology? What was your thought there?
Hi, this is Priscilla. So I think my thought was actually patient-facing technology. So computers, tablets, and then access to the internet. I know that I think Xfinity has a program that's that's low cost, and I believe recently Prince George's County and maybe Montgomery County provided some laptops that were also kind of free. So kind of expanding on that. So people have the opportunity to use it for healthcare, or if they're searching for jobs or whatever they need to use the technology for, and don't have to go to the library, you know, to use the technology. So that would be for adults and also for the young adults or children and families.
Awesome. Oh my gosh, I'm so excited about how many people are entering. Thank you all. Anybody else want to elaborate on your contribution?
Hi, it's Priscilla Lissick, the new person in the group. I have a quick question. Somebody posted something about dental care for RW patients, emergency dental care. What does RW stand for?
Yes, this is Ale Mose. Can you hear me?
Yes, we can.
Oh, yes, this is Ale Mose from La Clínica del Pueblo. RW stands for Ryan White patients.
Okay, and the reason I'm asking is because I serve on the MDAC Dental Committee, and I
Okay.
want to make sure everybody knows that they have updated the dental services through Medicaid. So all adults are eligible for dental services through Medicaid.
Oh, thank you. Thank you so much for sharing that info. Well, something that I should add to that is so we have, dental services for uninsured people, but not for those that don't
Yes.
qualify for an insurance. And so we serve the immigrant community in the
Mhm.
county. So we don't have
Yeah.
access for those individuals.
Yeah, we have the same issue because in Montgomery County, we are one of the few agencies that serves individuals who are not documented. So I understand.
Okay, volunteer be called on. Tara?
Hi. Oh, can you see me? It looks like is something wrong with my screen. I just put my camera on, but it doesn't look like I'm coming on. Maybe I'm having that Teams issue now. I'm the one that also has been having Teams issues. So if you no longer hear me, it means I've been booted off.
Okay.
But I wanted to share and kind of piggybacks on what just happened between Priscilla is a goal that maybe we can identify or achieve is what I mentioned, and this is my my contribution is creating a platform to introduce community programs with the focus on presentations to be who we are, what we do, and how to refer. Really, and it kind of imitates like an echo platform. It's something that we do at Mary's Center, and we've kind of contributed it a little bit wider to be. But anyways, I kind of wanted to suggest a similar platform that helps introduce so everyone can be aware of programs that maybe not everyone is aware of, right? And the population that they serve, and just the simple who we are, what we do, and how to refer. I think that'd be a great way of always staying on top of what's available, right? We always want to have a list of resources and community programs, and this is a way of integrating and introducing and always being in the know.
I like that. Yeah, I feel like this would be a good bridge to make sure everyone's registered for the December quarterly meeting, because Kim's inviting 311, I believe, potentially 211 and 988. So definitely like platforms that kind of capture parts of that. I don't think we have like a comprehensive resource quite yet, and I agree that's super needed. But they have parts of that that might be good to hear from. I love the community resource concierge. That's so fancy. Anyone want to expand on that?
Hi, Caitlin. No, I just wanted to, I think what we hear is sometimes, when you get things, people trying to navigate through the different resources, and there's so many, and we heard this sort of at the town hall meeting, is there's so many programs that people don't know about, that if we had sort of like a community health care concierge that they could call and be navigated and actually do a warm transfer. I think people sometimes can see something online, maybe they don't, or they don't have access to online. but it's then making that next call or getting them to actually take action. So it's always nice when you have a human voice and a person that's asking a few more questions to make sure you're clicking on the resource you need.
Absolutely. We talked about the dental care, financial assistance for how DPP costs now that we will be billing. I wonder whose that was. Would you like to expand, Tornisha, I'm guessing?
That wasn't
Although-
me this time.
Oh, I guess, yeah, right. That's right. It could be TLC too. Is that, I forgot we're both billing. Is that maybe?
Me. It was Cindy from TLC.
Want to expand on that?
Yeah, just the fact that now that we're moving into billing and charging, and I come from outside of, I come from a HMO background, so I don't know a lot about the billing and all of that stuff. So I'm learning all of that, but it just seems like we've had this free program for these years, and now we're going to move to billing, and there's going to be some people that aren't going to be able to afford the cost of it to be able to still provide some kind of grant or resources for people to be able to tap into that don't have the resources but would benefit from the program. That's all.
Absolutely. Tarnisha, if you are, you are here. I just called on you. Do you want to expand on, because like this is like Tarnisha's soapbox issue. Do you want to expand a little bit on like co-pays and stuff? I know you know so much about that.
So yes, so we have contracts with the Medicaid organizations, the MCOs, to cover the costs for the ones who do have Medicaid, and for the ones who don't, of course, the self-pay with the sliding fee schedule. And then, so that's what we have right now in place, but we are thinking about the ones who can't even pay for the ones that for according to the fee schedule, like what are some other options to cover those people so that they can continue to get the services. And so we do have a program here at the health department, the Living Well program, for the ones that can't pay. It's not exactly the same as the national DPP, but there's still a type of education that assists people who are pre-diabetic, and that's a free program.
Awesome. Okay, so in the other section, I feel like we have a good mix there. Let's see, behavioral health, create a master list of available resources in the county. So we saw that also in others. So that's kind of a theme that's coming out, I think. We also have centralized data warehouse. So yeah, so we have these sort of like technology resource inventory goals, it looks like, coming out. Somatic and behavioral health care together as whole person health, increase access to home health aides, behavioral health teams which can diagnose, treat, case manage, and follow up with persons who don't have the ability to come into an office or access telehealth, especially homeless. So that's good. That kind of bridges across our two areas. Anyone want to chime in on something they put for behavioral health?
Caitlin, this is Margaret. I just put together, looking at a whole person health, since we do have like the behavioral health group as well, and looking at it as, even though unfortunately, they're looked at differently, it still affects the same person as a whole person. So I think that would be important to do. And I know with the BHAG group, we're trying to really, that's one of the goals over there, is to make sure that we look at not only the somatic care, but also the behavioral health care, mental health services. We look at it sort of like a person on a bike, right? They have two wheels, right now, the medical one and the behavioral health one, but it's getting that person to the same place. So, and they need both.
Awesome. Build bilingual behavioral health capacity. I say we can go across the board on that one. We need that all over. So that's a great point. Technology and connectivity, increasing access, right? That was Priscilla, increasing access to low cost or free kind of patient-facing telehealth or otherwise technology, centralized community health data warehouse. It kind of sounds like that's similar to the one underneath. Is that what is that what you had kind of in mind? Like a warehouse where you could look at different indicators, across different systems to see kind of what's going on and maybe identify high utilizers and what we can do there?
I think not only that, but also, having different levels of access, certainly, but, let's look at social determinants of health. The hospitals have to do that, and doctors' offices are doing that. So, sometimes with each encounter, having to ask the same questions or answer the same questions over and over with a slightly different focus. If we standardize those social determinants of health screenings, a lot of it could be done. And, where we're integrating care into the emergency room, into hospitals, doctors, we're working with that right now. We're working with the doctor's office. It's already doing a social determinant screening. If they're already in the hospital, do they have to do it again? And so then everybody would sort of know if this person engaged with any of these services, that the social determinants of health screening would already be there and they wouldn't have to be asked over and over and over again. So that's just one particular item that I feel could be shared if we're all doing social determinants of health screenings. It seems like it should be shared. That way the person doesn't have to keep being asked over and over by every group they go to. And then it could be other things too. For instance, if there are, like we talked about DPP, if somebody has gone to the ED and they've been referred, then they can also say that, did they go to the DPP class? Did they not go? What reasons? Those kind of things. So that when the people are in a coordinated care, community care of DPPs, the doctors, the hospitals, the caseworkers, CHWs, they could see like, where does this person need that help? Are they attending? Did they get their medications? Those kind of things.
That makes a lot of sense. All right. Increased training for how to use telehealth technology or how to use technology and effectively leverage technology, i.e. cell phone use for seniors. That's definitely big. Low cost access to CGM for diabetics and pre-diabetics. So for those of us who aren't medical or aren't kind of chronic disease experts, what is CGM?
Continuous glucose monitoring.
Right. Okay, so like remote patient monitoring, or is that the one where they have the boop on their, yeah. Okay.
Yeah. They don't have to keep sticking themselves.
Yes. Yeah. Okay. I want to ask a question because I see the combined data sets across systems is its own sticky, and it looks like somebody put a check. I'm thinking like, I feel this way too. So I am wondering, one thing that CCCT used to do was it had, I think, like this predated me. So Dr. Carter, please, or Ursula, I think, please, or Kelly, if you're on, chime in if this is not representing correctly what happened. But that there was a subgroup that had like signed data use agreements and like legal relationships so that they could actually discuss. And I think Jay, you were here also, discuss actual patients who were high utilizers and who might be the best to intervene with those patients. Is that right? Is that how it used to work?
For my now, please don't rely on my memory. But from my memory, we did have that. It would be for this group. It would be also be important. Everybody had to sign those agreements so that we could openly discuss a case. Now, I can't remember. I don't know whether we did that in a subgroup or whether we did it for the whole group. I just don't remember. But it seems like it was for at least the whole group, at least for some cases, but I just don't remember.
I think it was a subgroup.
Mhm.
Yeah, it probably was a subgroup, because.
It was, yeah.
Yeah, yeah, you would know, Ursula, because I think, yeah, it's, golly, that's been a long time ago. But, and several there have been pandemics and stuff that's happened since.
Pandemics ago.
So,
but-
yeah, so my pandemic brain won't remember, but if it was a subgroup, Ursula, that's what you're saying?
It was a subgroup, and I think it had to do with the community health workers because they worked those cases. And I know I was there, the old PG Hospital group before it became University of Maryland was there because we all shared patients and the same type of cases. And then we would discuss the cases. And we had some other entities we could refer to or could assist us in taking care of those patients. I can't remember everybody that was there. I think home health was there. There were some other entities there.
Right.
Insurance payers were there. And so then we would discuss high utilizing difficult cases.
I think that's still a really good thing to do, especially when you get the folks from the emergency rooms and from the hospital systems, the payers, the people who are getting referred to, like how the major, some of the major entities, housing, food insecurity, blah blah blah, all those in the same room. And then to discuss cases, that was very, very fruitful. We could take the results of that and, and de-identify the data, bring it back to the group as a whole, so that we can, that would add tremendously to how we think about, really governing these interventions. So that's a very good point. I had forgotten that, and thank you, Ursula. Thank you, Caitlin, because I think that was very productive, as a matter of fact.
Yeah, and I feel like if we have a goal that is like, I'm just throwing an example out, but we could have a goal that is like better manage or not manage. That's not a cool way of saying that. A better serve the high utilizing population in Prince George's County. And then maybe our sub goal is like, enter into, or our action. I always get confused about which like objective strategy, action plan, whatever, but our steps are, define the legal relationships that are necessary for that, enter into them, and then, build a structure for how to discuss cases. I feel like I went to like one of those, and it was a subgroup where they had, I remember we discussed in like initials, we had people's initials and then discussed like the different cases. And it was really helpful because the people were hitting everyone, and it was like the same people were everywhere. And so we could figure out like, okay, but you're really best suited to serve this specific issue, you on this specific issue. Yeah, Jay, did you want to chime in?
Just a couple of this reminds me of conversations that happened that just predated my time around data-driven justice, determining who the high system utilizers were. I know that Renee did a lot of work helping to identify, we had a couple of clients who were like $1 million clients, like, you hear people talk about receiving $1 million worth of interventions across criminal, legal, housing, emergency rooms, fire EMS. What you were describing, Caitlin, also reminded me of the fire EMS mobile integrated healthcare meetings where we did case conferencing with people's initials. And since their system specifically pulls high system utilizers from 911, I remember those meetings also. It touched a lot of different cases. And even if we didn't solve that particular case issue, I remember it being a very productive conversation because the hospitals and the shelters and the outreach teams, behavioral health, got to learn a lot about what the other system, how the other systems functioned. People had assumptions about how you get into emergency shelter. And because I was in that meeting, I was able to say, actually, it's a little different than that. It might not be working properly, but here's how it does work. So I remember those meetings being very productive as well. And I know a lot of the people who had participated in those have really missed those monthly meetings.
Do they still, so they don't, so fire EMS doesn't do those anymore?
They don't do those meetings. They
Okay.
do still have the mobile integrated healthcare team. Evan handed it off to somebody who then handed it off to China Pinkney, who is currently running the mobile integrated healthcare team in Fire EMS. She's great. They participate in like those community street outreach meetings, but they're really like underwater in terms of time. I think that's why those sort of coordinating those monthly case conferencing meetings hasn't started back up again, but I'm sure they would participate. I know China has been great about working with local law enforcement, outreach teams, behavioral health, right? Like she's really committed to that sort of cross system collaboration.
Yeah, we also worked with her as well. We did a pilot with them to enroll patients that was high frequency callers to 911 to see if they was eligible for some of the prevention link programs. And what we find through the course of that pilot, a lot of those patients needed like home nurse assistance with their daily livings, and a lot of the patients needed like Meals on Wheels. So we was able to connect them with our community health workers to get them connected to the resources that they need. But she's great. She's definitely a good partner.
Awesome. Let's get her here.
I have actually forwarded the meeting to her. I think she may not be able to, she just doesn't have enough time. I have forwarded the meeting to her, and I told her that they used to participate in this meeting, so.
Okay, well, everybody talk to your friends still and see if we can influence them in.
Caitlin, I have a question and a comment. This is Gina Greenhood.
Hey.
My first question is this: under behavioral health, it says increase access to home health aides. Can we talk about that? What does that mean, and what specifically is that about in terms of behavioral health?
Whose was that? Don't be shy. All right, I'll read it again in case someone was a little distracted. So we're looking at the goal that was added: increase access to home health aides. Who wrote that, and would you like to expand on what you meant?
Okay.
All right, maybe they had to take another call or something, so we can ask that again in a bit.
Well, then I'll go into my comment. Can we put something under behavioral health about expanding the access and availability to evidence-based practice models? Something that's essentially in line with recruiting quality providers into our county to provide evidence-based practices.
That's a good one.
Thank you.
And is your thought?
Can I ask you a question about that? You can,
sure.
So what motivated you to include that?
Well, I mean, I'll be honest, Dr. Carter, I think we have a lot of behavioral health service providers in our county. But what we don't have is services that are geared towards proven, qualified services that have shown to be effective. And so I think we have a lack of, and I'll just use this as an example, which would be trauma-informed care. We might have providers that have had some trauma training. They might have taken a course or two, but in terms of having any certified trauma providers. We really don't. It's very few and far between. We could certainly use another ACT team, assertive community treatment team, and even expand that to address children's needs. You know, things like that.
Yeah, I got it. I appreciate, that's what I wanted to hear from you. I just wanted to hear, because you see a significant need, and if you're trying to coordinate care of individuals and you refer them to either a provider who is not using evidence-based care or not as adequately informed, or if our children there's a big gap for our children, then that's once the CCCT, all these things on the board are things that the CCCT has to recognize. Can we solve every one of these? No, but what we can do is start to make sure that everything that we put here we can at least advocate for improvement in the county as we move forward. Because we can't, what I don't want to do is to get these things and then say, okay, we're going to do 1, 2, and 3, and all these other things, they're great, but we can't really address them. No, we're going to do 1, 2, and 3, but these other ones will be addressed so that we can keep, we may have, we'll hand it off to the PGHAC and the other parts of the Health Action Coalition, et cetera, et cetera. But we still have to be acutely aware that that's something that we have to work with outside entities to make happen, and even to the point where we can change the policies in the county.
Exactly.
Or with synergistic with whatever's going on with the state. So I appreciate everything that everybody has written on here, and I went on the behavioral health side. I do know that there's a big gap, so I appreciate you telling me that.
Great, thanks.
You're welcome.
All right, Jay, did you have something?
Yeah, if we're asking for clarification for some of these points, if somebody wanted to clarify the LGBTQ friendly shelter services in the county, and that can be a side conversation, I'm going to put my information in the chat. I'm a member of the queer community, and I exercise oversight over shelter intake in the county. So if our service and all of our HUD funded shelter services are required to be affirming and welcoming. So if whoever it was that put that wants to chime in now, or if they want to follow up with me, I would love to know what you meant about that.
Awesome. Anybody want to chime in, or if you're not comfortable, totally follow up.
Well, this is Ale Mose again from La Clínica del Pueblo. It was me who put that about the LGBTQ friendly shelters in the county. So yeah, it will be a pleasure to follow up. And also a member of the LGBTQ community, and I'm a transgender individual, and let's talk. It will be great. And so we can find ways to help our community. Thank you so much.
Awesome.
I look forward to it. Thanks very much.
Okay.
Thank you guys. This is so positive. I love how like open and collaborative this is. This is great. So I know I see Priscilla, your hand is up.
Hi, yeah, and so I've just been listening to the entire conversation, and it's really inspiring to see everybody working so closely together. One of the things I just wanted to throw out there, our homeless services division at the coordinating center, one of our area of expertise is providing services through the Medicaid Assistance in Community Integration Services Waiver Pilot Project. And so we provide services in other counties through ACES, which allows the county, I think you guys probably know about the program, it allows the county to recoup more funds from the state. And so as I hear the conversation, I think that's where case managers who are able to provide services under that project could be very helpful in facilitating a lot of what you're talking about.
Absolutely. And it seems like that has come up in a couple different areas here. So I know I didn't go through everything in housing. So, real quickly, it also says housing ombud to advocate and help reduce barriers for folks who are homeless and at risk of homelessness. That sounds like exactly kind of what you were just talking about. We covered the LGBTQ friendly. We talked we talked about, I think, emergency dental, but rental assistance program also. I know we see lots of need for rental assistance. And then the emergency shelters being able to, address those somatic and behavioral health issues. So this is awesome. Thank you all so much. I think what we're going to do is take all this feedback and the discussion and brainstorming that we had today and go back and try to see if we can kind of organize these thoughts and back into some like larger goals that might work. And then when we reconvene, we can talk about, what if these goals are sounding right to you all, if we want to tweak them, and then what our steps are going to be within that. So this is an excellent place to start. Thank you all. Brainstorming is like pulling teeth sometimes, but not in this group. Everybody's so engaged. And so I love it. I do want to encourage you, if you didn't get your thoughts on here, this is what we're going to be using to develop those goals. So if you didn't contribute your thoughts, or if you're having a thought that you want to put in the chat because you kind of are not in a place where you can access the Jamboard, or even if you want to send it to me and Kim via email, just please make sure that you are chiming in. We want to make sure we're capturing the feedback from like all the different areas of the system related to care coordination so that the goals that we're developing fit right with everyone. And I will thank you all again and turn it over to Kim.
Thank you. Again, yes, such a great and inspiring discussion. So thanks all for participating. We wanted to give some time to Mike Nazeni from the Health Department to discuss Pathways for Health Equity Project and their upcoming plans to expand to mobile. So Mike, you have the floor. I think you might be muted.
Thank you, Kim. Thank you very much. For those who don't know, we have a Pathways to Equity project that we are running currently in the county. And the goal is to reduce the health disparities, to improve health outcome, to improve access to primary care, to promote prevention services, and to reduce hospital admission and readmissions. For that, we have a group of CHWs who meet with residents, and they run a social determinant of health assessment to identify the needs they might have, and then they will connect those the resident to the services or resources available in the county. So currently we have, next slide, please. Currently we have 4 hubs. These hubs are in Brentwood and Capitol Heights, Hyattsville, and also another one in Capitol Heights. The idea is to have CHWs, sitting in the hubs, and the resident will come and meet them there, discuss to find out their needs, and then try to connect them to resources. For example, if they also have a telehealth appointment, the community health workers will have tablets and computers where they can connect to the health services. So we are trying to make sure that people are served, people are reaching out to our CHWs. Unfortunately, people are not really coming to these hubs as we expected. So our targeted zip codes are there. These are Bladensburg and Riverdale, Capitol Heights, and Hyattsville, but we can go everywhere. Currently, we are trying to have CHWs located in the emergency rooms in the hospitals. Yesterday, we had a very nice meeting with a hospital. So I think this will help us to have more access to resident, to patient in the ER. On top of that, we would like to use our mobile vans where CHWs can go everywhere in a county, especially in the zip codes. We have drivers who are trained now to go with these mobile vans. The idea is CHWs will be in the mobile van and then we'll park the mobile van in a very busy area, for example, and then people will come and then we'll ask their questions. We can take their contact if they don't have time to have their social determinant health assessment done there. We can take their contact and then we can contact them later on. So now we want from you to have your idea, your suggestion on where we can park these mobile vans to meet residents. So I will put a link in the chat so that you can put your idea, you can suggest a place where we can park the mobile van. It can be your organization. If you have, for example, a health fair you are organizing or an event, we can also go there. Or if you know a place, a busy place in the zip codes or anywhere else in the county where we can park the mobile van, please, you can write in the Google form so that we can reach out to those places, to the contact persons to have our mobile van there. So this is the idea to have thus your suggestions. Thank you, Kim.
Thank you so much. And we'll be sure, Mike, whenever you add the form, we'll also put that out with the notes so that everyone can respond. Sharon, a question?
Can you hear me?
Yes.
Okay, thank you. Yes, I did have a couple of questions because, I was curious about what sort of marketing you did for the hubs and if you had any idea why people aren't coming in. It's just, it's curious. And I think, people create these hubs and have people sitting there and it happens a lot. So, what's the issue and is it marketing or is it just that people aren't is there a resolution to having people come in?
Yes, that's a very good question. At the beginning, we thought that, people were not informed about these hubs.
Yeah.
I think we ran a marketing on the TV and it went off. It was good. And then in these marketing sessions on TV, we've put also our phone number so that they can call us to schedule an appointment, for example, in the hubs. What we've realized, people are more calling our phone to get services online, on phone or via emails instead of coming to the hubs where they can really meet the CHWs. So, I mean, they want more to talk on phones, but not willing to come to the hub. When they come to the hub is really if they have something to do, like we have a Langley Park multi-service center. When they go to this hub, it's not especially because of the pathways served, it's because of the other services in the center. And then they come also, they meet our CHWs. This is the same with the community outreach development of CDC. They come for other services. But for AWPLI and Belua Baptist Church, this is only pathways services. And then we don't have many people there. So they come for other services and then they meet our CHWs. Yeah, that's it.
Exactly. So our recommendation to anyone who's interested in following this kind of model is it has to be in high traffic locations where you're just intercepting people who are already there. Which is kind of obvious, but we just looked at organizations with space to rent in our project areas. We also we started by looking at parks and planning or libraries, and the reality is everybody, when this grant started, everybody was in such a state of repairing after COVID and losing staff that it just wasn't the time to set up or take on new initiatives at a lot of those high traffic locations that the county sort of already owns. So we sought locations that were in areas of, of interest in these zip codes, and it sort of didn't work at some of these places where like it was almost like we were creating a barrier by then asking people to come in person. So it didn't quite play out like we necessarily planned for it to at all the locations, but at Langley Park, for example, super well utilized because people are already there for other things, as Mike said. So it was a learning experience. And our next time we'll be locating, I mean, our most fruitful sites are like in FQHCs or in hospitals. So that's where we're kind of trying to moving forward. But yeah, that's why we're a little bit lower. So that was the idea behind starting up the mobile van, is that we can go to, you know, locations where people are a little bit more versus trying to get people to our locations.
And it looks like Gina has a question as well.
Yeah, actually, this might be a really uninformed question, but I'm going to ask it anyways. But I do have a comment first. I just thought about, have you thought about any partnerships with local schools in these areas to reach, you know, families? Because that is a good place for access to services. And my question is, is this Pathways to Equity, does that include behavioral health, or is this just all somatic?
So it's community health worker services. Initially, the plan was to also connect via telehealth to clinical care, both behavioral and somatic, at an FQHC via telehealth. And so that has ended up being a little bit more difficult to get off the ground than we kind of initially thought. So we're still kind of working through what that would look like. But that, yes, we certainly have behavioral health as a critical referral pathway, if nothing else, in our workflow.
Okay, well, I do have some ideas about how to connect people to behavioral health. I mean, we do have some providers that will do in-home therapy that doesn't require the family to come to them, number one. Yeah, I just have some other ideas I think I'd like to try to flesh out and maybe share with you. I also think our local behavioral health authority has some knowledge and information about our provider base and can certainly provide information and resources on what's available.
Yes, yeah.
Well, I know everyone probably has additional meetings coming up, but this has been a great discussion. I just asked Mike if you can add your contact information to the chat, and then we will send the form out. It looks like we might have to make an adjustment in the form to open it up to people outside of the organization.
Okay.
But thank you so much. And so upcoming, we decided not to meet in December because our meeting would be right in the middle of lots of December holidays and time off. So we appreciate everyone's work and time, and you deserve that time to rest if you're able to take it. We do, however, have our quarterly meeting coming up, the Coalition quarterly meeting on December 12th. Taylor, if you could add the link to that into the chat. So this will be an in-person meeting at the Kentland Community Center, December 12th at 6 p.m. We do, as Caitlin mentioned before, have speakers representing 211, 311, and 988. So we encourage you to think of some questions that you have for what resources those call centers are connecting people with and how we can help utilize those resources to engage more health resources in the future. So please join the meeting. We look forward to having you there. We'll have hot meals. And then, as I mentioned, we're going to cancel the December meeting, but we will meet again Thursday, January 25th. We'll keep the Jamboard open if you have any additional ideas, and then we'll have some follow-up in January. Any closing remarks, Dr. Carter?
No, just thank you guys for coming, and I look forward to a very active 2024. I think we're going to do some great things in that year. So thank you guys. I really appreciate it. And this discussion was excellent today. Thank you.
Thanks, everybody.
See you guys.
Take care.
Bye-bye.